Elaine, could you go over a little bit about how the currently available therapies are used for the treatment of Alzheimer's disease?
Well, as you know, Jeff, the FDA-approved medications for Alzheimer's disease include 3 cholinesterase inhibitor drugs and 1 NMDA receptor drug. And I think I'll tell you what I tell my patients. I say to my patients and their families, my goal is to keep you the way you are now for as long as we can. And so it is really to try to plateau them for several years, try to slow progression. And I've been in research and clinical practice in Alzheimer's disease for 40 years now. And so I've had the experience of taking care of patients in the era before these drugs were approved and the era since. And I've even taken care of siblings with mutation-caused Alzheimer's disease, one before and one after. And I feel that it is different. I didn't used to have patients who would stay level for a year, 2 years, maybe even 3. I had patients that would sink like a stone in the era before, and I really do think they're a benefit.
Mm-hmm. And Ali, I think you've written about the benefit of combination therapy in terms of disease stabilization.
I have, Jeff, and I think your experience, Elaine, is true, and it's backed up by evidence now. 20 years of meta-analysis and reviews for both randomized clinical trials and then observational cohorts beyond that show that there are benefits for groups. And the question is really which individuals have greater benefits. Some may have smaller benefits. We don't know that. So that's why, as part of the strategy, is to actually explain to individuals, the patients and the care partners, what the expectations really are. And people want maintenance of personhood, of quality of life. They want to delay disability. And I think the totality of the evidence shows that these medicines can actually do that and help. In mild to moderate stages of Alzheimer's disease, as a group, patients decline within 6 months quite a bit, even in randomized controlled trials in the placebo arms. So we know that this is actually an aggressive disease. So having stability actually for 6 months or a year overall is a win for us. In the long term, sort of decreasing decline. We can't stop the aging process and other things. We do lose function. So for me, I really want to make sure that people have the knowledge and appreciation and the right expectations for these drugs. So that's one. But actually, my first thing that I do is actually I do a med review and get rid of the redundant medications. If I look at Beer's criteria to make sure if there are anticholinergic medications, I get them off that. I get some benefit from that. The other things I do is I want to make sure that comorbid conditions are treated correctly, so their blood pressure and glucose and things like that. There's data that if you do that, actually people benefit and they're on a slower path of decline. The other thing I do is if there are other comorbid conditions like true depression, I want to treat that. And I'm somebody that actually still uses vitamin E in the right individuals, because 2 randomized controlled studies have shown that actually it could decrease decline by about 20%. But I would say the cholinesterase inhibitors, stage appropriate, starting on the earlier time scales, and then adding memantine is a good strategy. And there's a lot of data for that.
So sticking with the theme of cholinesterase inhibitors, Marwan, I wonder if you could talk a little bit about the mechanism of action of these drugs, where they're indicated, and what are the efficacy expectations?
Yes, so the cholinesterase inhibitors have 3 in the class: donepezil, rivastigmine, and galantamine. They are acetylcholinesterase inhibitors, so the neurotransmitter acetylcholine is released from the one neuron. Is supposed to be bound to the postsynaptic neuron through 2 receptors, either muscarinic and nicotinic receptor. It's degraded by an enzyme called acetylcholinesterase, and the inhibitors basically prevent that degradation from occurring, so that the acetylcholine will stay in the neurotransmitter stays in the synaptic area longer and has a pro effect on electrical discharge, transmissions, etc. That's how they work, and the data suggests it's a normal mechanism. We've borrowed that from peripheral disease 25 years ago when we did the same thing with myasthenia gravis for apridostigmine. So this is a central adaptation of that concept. Because we understand very early on that there's a cholinergic deficit. Memantine or NMDA antagonists are partial glutamate sensitive, a partial antagonist of the glutamate receptor. They're not a total antagonist like ketamine would be. So because some of the absolute antagonists of NMDA receptors have been shown to cause psychotic features, whereas memantine does not. Memantine is supposed to normalize calcium homeostasis and therefore restore glutamate function back to a normal state. I find these drugs work synergistically. I would not say it's one to the exclusion of the other. I will say that the cholinesterase inhibitors do have a strong class effect around GI side effects, nausea, weight loss, anorexia. And that's, I spent a lot of my day job managing those, I will say that to you. So I actually tend to use these drugs in conjunction with the other, meaning a cholinesterase inhibitor with a memantine, not cholinesterase inhibitors ever together. I would never do that.
The major thing about that, Marwan, is that I think one of the things I really make sure is to teach people the strategies about monitoring. So I find that a lot of the reported side effects are in individuals who are taking the medicines themselves. So they go on and off, they may double up, they may be dehydrated. Some of the other issues are they may take it at night, and so it keeps them awake. So I really, really make sure that now they have a partner and they're not leaving it up to the individual with a memory disorder to actually take their medicines. So for cholinesterase inhibitors, in the morning after breakfast. And it's something that's supervised and monitored with a pill box. So I think those things are really, really important that can diminish really the side effects.
Well, that's a great point on the practical management of these medications. Elaine, how would we know whether the cholinesterase inhibitors and memantine are working? What are the measurement strategies?
Well, there are a number of things you can do, and I do a structured cognitive screening test every year, like the MOCA or the mini mental state. However, my real, you never know in a single patient whether they would be doing worse if they weren't taking the cholinesterase inhibitor and memantine. So I take a fairly informal approach. If the caregiver feels that the patient is doing pretty well, I continue. And I think this is continuing until very late stage disease.
Mm-hmm. So the information from the caregiver is the key thing.
To me, that's the most important thing, and I supplement that with a cognitive screening test.